Good morning. I would like to thank Dennis for his kind invitation to present this topic, which is very near to my heart, what is new in venous stenting 2018. I would like to thank him very much for this kind invitation. We did collaborate in a lot of activity, and we all like his lectures here in Egypt. And we have very high admiration toward Russian vascular science. And I would like to say, I hope it is right. Duplitracien. Topics I'm going to cover quickly: changing pattern in management of venous disease, prevalence of venous disease, and what is new in venous stenting. In my old days, in my training, we used to do deep venous surgery like iliocaval bypass or femoral venous bypass or paloma procedure or valvoplasty, which was very difficult procedure, and all of this is now history. No indication anymore for deep venous surgery. Now, if you are going to practice venous disease, you know that you will be very busy over the next coming years. This is prospective study about the future of VTE, and you can see it will be increasing until 2050. Iliac venous obstruction. Is it really important to treat an iliac vein? This is one of the landmark paper by O'Donnell, which has followed up a patient with deep venous obstruction for up to 10 years, and he has discovered dramatically that 11 of 12 men will be disabled. You can see the amount of impact, and 7 of 9 women will be unable to perform household duties, and this is really catastrophic consequences, and I don't think the paper will be repeated anymore. How does the vein look from inside? It looks with a lot of fibrosis, a lot of synecia like this. That is why it's very difficult to pass the balloon, and balloon can easily rupture. And when you do a venogram, sometimes you don't realize how much difficult synecia are. I will summarize after taking a few courses in venous intervention. I will summarize what I have used to do in the past before these training courses and what I do now. And there is nearly 180-degree shift in my practice. Now, I used to work without evidence. I couldn't say to the patient what is the evidence that he will get better. But now I can tell him that we have a grade 1B recommendation for disabling symptoms and grade 2B recommendation for patient with less disabling symptoms. And this is from Klovinsky guideline 2012. Secondly, I have learned that venous stenting is more or less essential. I used to do it under local anesthesia, but because it is very painful, now I do it under general anesthesia. So I've changed regarding anesthesia. Imaging, I used to ask for duplex scan plus or minus CTV, but now I ask for a big group of duplex scan, CTV, MRV, or ascending venogram. As you can see, this is a case of ascending venography, where I put 2 10-centimeter needle in each popliteal vein, inject a dye, and see simultaneously flow in the veins. Tools have also changed dramatically. I used to have just a trumo and vertebral catheter, nothing else, and I had a lot of failure. But now I use trumo, vertebral, hydrophilic catheter, support catheter is essential, and also I use CTO wires, 2 or 3 CTO wires. That is why the failure rate have dropped dramatically. I used to have a balloon angioplasty only for these cases, but it doesn't work. This is a patient with occluded IVC, which took me maybe around 30 minutes to do crossing with the wire, balloon dilatation, up to 20 millimeter balloon, and the ballooning to the iliac vein also was very difficult. And you can see the amount of stenosis in the IVC with the balloon. And after all this, if you inject a dye, you will get complete occlusion. So there is very high recoil in vein. Without putting a stent, you're just asking for very high failure rate. So you can see in this picture, after multiple balloon dilatation over a long period of hour, when you do injection, you can see the balloon even moves freely, what is called ballonogram. You see, little bit of stenosis there. Here it is in the iliac. You can locate it with this trick to work like an IVUS, and you can balloon it up to 12 millimeter, which is painful. If you inject a dye, it doesn't work. Occlusion is the same. So just balloon, you can see here, nothing happened. Still occluded, and you can see collaterals. Where is the vein bend? We were worried to put a stent over the groin, but actually the vein does not bend in the groin. It bends very deep down over the internal iliac vein, and this is the site where it occludes. So there isn't any problem putting a stent over the head of femur. I've also used another trick. If you're unable to do crossing, you can put a wire into the normal side and have a 90-degree view, like this one. You get a 90-degree view, and then you can try to follow with your wire the occlusion to follow this. It gives you like a road map to the occluded vein where to go. IVC stenting, I used to be very worried about the IVC to put a stent. I'm not worried anymore. It's actually becoming routine practice. This is a patient with IVC occlusion. I was able to do balloon dilatation 24 millimeter by 10 centimeter, multiple balloon dilatation, as you can see. And then I've put wire from both sides, and then you can put a stent. You can put 24 millimeter self-expandable nitinol stent. This is what will maintain your IVC patent. And after that, when you get, here is the stenting of the IVC, and you can get a good results after putting the stent. You do also balloon angioplasty. If you don't have a bigger balloon, you do double ballooning, which means 2 8-millimeter balloon. And then you need to correct the iliac as well with iliac stent, and you can do double kissing stent in both iliac veins to maintain the inflow to your IVC stent. And then if you have another stenosis, you do dilate another stent, and don't worry about crossing the groin. And we'll show the final picture of this patient after the balloon dilatation. This is the final run. You can see very good and complete disappearance of collaterals. Why we use IVUS? Because it's very important tool to tell you what is inside the vein that you can't see with a venogram, with injection of a dye. You wouldn't see this amount of synechia, you wouldn't be able to see it and appreciate it. Venous stenosis was tried to define venous stenosis according to the imaging, and you can see the difference between the vein before putting a stent, after putting a venous stenting, like in May-Turner syndrome. These are the pictures of multiple veins, how you can assess the vein diameter, and you assess where is the problem and how to solve it. Poor man IVUS, in some center in Egypt, we are unable to get IVUS, so what we do is put a semi-inflated balloon and move it up and down the vein to give you what is inside the vein. Dissection, you can't go subintimal into a vein, but you can cause a dissection, and dissection usually equal venous stenting, and it is not uncommon. IVUS now is becoming a routine practice, and this is one of the cases. This is one of the cases that of May-Turner syndrome, with you can see the pre-intervention run with the stenosed vein, and you can see after putting a stent was wide. You can see the difference between pre and post, and you wouldn't get this imaging with other modality other than IVUS. Balloon dilatation, I used to have large balloon. I used to do gradual dilatation, but now I do just straight on one large balloon, no gradual dilatation. I use Atlas balloon because it's a high pressure. I always put venous stenting, no case without a stent because it will occlude. I now started to stent inferior vena cava as well with a bigger balloon. I used to have selected cases of chronic venous obstruction. Now I do CTV to all the patient, and I do intervention for CEEP class 4 and 5. CTV and MRV are usually very helpful. 3D reconstruction is also very important, and IVUS is a recommended tool, of course. I used to have a duplex guided prone position, and I used to go to the groin a lot, which is a problem because the groin is involved. Now I do duplex guided to common femoral vein, superficial femoral vein, and popliteal vein as well. I do crossover maneuver, same as in arteries, which I didn't use before, and it's a very nice trick. I've also used the trans-axillary vein approach or trans-internal jugular vein approach. Silver vena is a good stent, which was not available before, and I used to stent from normal vein to normal vein. Sometimes this is difficult, so I stent from normal flow to normal flow. Balloon angioplasty to 10 atmospheric. Now I use a high pressure balloon that goes up to 20 atmospheric, like the Atlas balloon. And we have a stent available, and I use a lot of CTO wires. I've also learned general anesthesia instead of local because it will make me able to have very high pressure without inflicting pain to the patient. I used to go to superficial femoral vein mid-thigh instead of the groin, and I usually follow from normal flow to normal flow in the veins. These are two things that I've also learned. You can see this is a freehand by Accuson, which is a handheld Doppler that is connected wirelessly into the machine, which is very helpful. So you don't have any cord or anything because all the venous puncture are duplex guided. And even the duplex machine become like a tablet with a touch screen that you can arrange. This is another device in Germany called Isono, and even it will give you the trajectory of the needle before you do your puncture. So you can see, you adjust the picture, adjust the gray scale, and then when you put a needle, you put it in a liquid that give her GPS recognition, and when you direct the needle, you can see it will show you exactly where you can hit. So venous puncture really become with this tool extremely easy maneuver. This is one of the tools that I have learned. So my conclusion, we have a strong evidence to treat chronic venous occlusion. We have modality to diagnose deep venous disease like CTV and MRV. The high cost of venous intervention is still a problem in my country. There is now a dedicated venous stent like Silver Vena or Venici stent, and we have to do more and more venous intervention in the future, and I would recommend every hospital to have his own venous unit. All modalities are done in conjunction with medical treatment and graduated compression stocking. I would like to end up by a sentence from our Quran, which mention وَفَوْقَ كُلِّ ذِي عِلْمٍ الْعَلِيمٍ, which mean whenever you got knowledge, there is someone who have more knowledge than you. And thank you very much.